Management of head injury. So, in patients with head injury, first of all, we have to suspect a cervical spine injury as well. Therefore, the first step should be to secure the cervical spine by using a Philadelphia collar. And secondly, we would monitor the GCS of the patient and grade the head injury according to the GCS. So if the GCS is 15 out of 15 and the patient does not have any loss of consciousness, then that means it's a minor head injury. And if the GCS is 14 to 15 with loss of consciousness, then that means it's a mild head injury. And in case of moderate head injury, the GCS will be 9 to 13. And if it is severe, then the GCS will be less than or equal to 8. So if it is a mild head injury, that is GCS of 14 to 15 with loss of consciousness, then all you have to do is take a CT, observe the patient, and if the CT is indicated, then only you need to do a CT. You can just observe and evaluate the patient, and then if the GCS is staying 15 by 15 with no focal neurological deficits and the CT is normal, then that means you can just discharge the patient. So if the head injury is moderate, that is GCS is 9 to 13, then that means you have to admit the patient because the GCS is low now, and then you have to do a CT scan and then monitor the patient, and then you have to serially do a contrast enhanced CT or CCT. And if the head injury is severe, that is if the GCS is less than or equal to 8, then you have to intubate the patient and then take a NCCT if it is indicated. So after doing an NCCT, NCCT will show if there is an intracranial bleed, that is an intraparenchymal bleed, or if there is a intracranial hemorrhage like a subdural hematoma or extradural hematoma or an SAH, all those things, or if there is any skull fractures, all those things can be monitored by using an NCCT, and then you have to further go for the management accordingly. You have to treat whatever condition is there, you have to treat the condition. Mostly it will be a surgical management, and patient has to be taken up for surgery immediately. Also, if it is indicated, then you can start a medication for anti-epileptic medications for preventing seizures in the patient. If there are no indications for that, it's not routinely given, but if there are indications, then you can go for anti-epileptics. Yeah. Now coming to the secondary brain injury that is caused due to raised intracranial tension and cerebral edema, that can be managed by giving adequate oxygenation to the patient, and then post the oxygenation, adequate oxygenation, and then you have to make sure that the BP of the patient is more than, systolic BP is more than 100, and you have to give IV mannitol and make sure that you do not give, you avoid hyperglycemia, so you cannot give dextrose based IV fluids to the patient, and here you can give prophylactic anti-epileptics. It is not routinely indicated, but usually we do give. Yeah, so this is the management for raised ICT in head injury.
I want to see myself as a good doctor in AMC, as army runs in my blood.
I want to work with Armed Forces Medical Services as a successful doctor.
So I would like to share some questions so that you can tell the other students also. So I was asked by board 2 firstly about my name, then to tell about the college name, and thirdly they asked me about CPR, the dose of epinephrine, adrenaline used in CPR. Then they asked me about anaphylaxis, the drug of choice. They specifically wanted to hear epinephrine, and then they asked me about dengue prevention, what measures can be taken, and they asked me measles vaccine, and yes sir, these were the questions asked.